Looking at typical pain that patients get from appendicitis, classically the picture is of central abdominal pain, which then migrates to the right iliac fossa. Typically the patient will be generally unwell and have quite a short history of this deterioration. They may present with systemic changes such as tachycardia, pyrexia, and in the later stages they may have localized peritonism in the right iliac fossa, typically at McBurley's point, which is located 2/3 of the way from the umbilicus to the anterior superior iliac spine of the pelvis. The reason for this change in the presentation is actually really quite interesting. We see that in the beginning there is generalized visceral pain from the inflamed appendix, which itself is part of the midgut structure. The midgut running from the midpoint of the second part of the duodenum to 2/3 of the way along the transverse colon. As the appendix is within this point, the pain is felt in the midgut and therefore is more central. However, as things progress and unfortunately the appendix gets more inflamed, it starts to affect the structures around it, which may well be the peritoneum overlying it. At this point there is pain felt directly from this area, and the pain will start to localize to the right iliac fossa in the patient. If we now look at how you might identify the appendix intraoperatively, whether that be with an open procedure or laparoscopic procedure, we see that the base of the appendix is located at the end of the tinea coli, which is found on the ascending colon. Therefore, if you manage to find the large bowel and you're in the right area, you can follow the tinea down, which should locate the appendix. You can then walk the small bowel from the terminal ileum along to see if there are any other abnormalities. The lie of the appendix varies greatly, and indeed the appendix itself may be retrocecal, i.e. lying behind the cecum, so may not immediately be obvious when looking for it. Typically during appendicitis, a small fecalith, a remnant of feces, will get trapped within the appendix tubular structure, which is a blind ending sac. This will start to increase the pressure within the appendix and eventually lead to swelling of the tissue there, which will further increase the pressure and start to cut off the blood supply. This will lead to tissue necrosis and eventually can lead to a gangrenous appendix and one that perforates. In the event of perforation, this may cause systemic upset to the patient, but this can wall itself off, particularly if omentum is overlying, and indeed this is when an appendix abscess may form.